We are here again on Thrive Academia Corner, where basic discussions are offered. The topic being obstructed labor. Obstructed labor. So this obstructed labor is just a complications of delivery, and it's an obstetric emergency. If not managed properly, these are the same conditions which are increasing the number of maternal mortality ratio. So obstructed labor is just a failure of the presenting part to descend in the birth canal in spite of good uterine contractions. So these faults, they can be because of the passage or the passenger, but the end result of them, they are producing an impassable barrier. So in as much you are dealing with this condition, you can do your quick interventions or the interventions that you can think of during the delivery. But if it is persistent, putting or producing an impassable barrier, meaning it is diagnosed as obstructed labor. So this obstruction, they can occur at the inlet of the brain, or if, they can occur even in the cavity of the brain, at the outlet of the brain. So the obstruction can occur anywhere but in the pelvis, inlet, cavity, or brain. Now, what are the same causes of obstructed labor? We had classified the causes being from the passage and the passenger. So the passage, we are just talking of the birth canal itself. We are talking about the pelvis itself. But when it comes to the passenger, we are talking about the fetus itself. So let's start with the passage. What are the causes of obstructed labor that that can cause an obstruction in the passageway of the fetus? So one, we have got the same contracted pelvises. They cause CPD. These contracted pelvises, they are more common in women with android pelvis, like even those undeveloped pelvises, like in prime gravidas, or women of less than 18 years. Their pelvises are not fully developed, so they can tend to obstruct the labor or cause CPD, which is going to lead to the same obstruction. Then also we have got the same spinal anomalies. These women with spinal anomalies, they tend to narrow the outlet of the pelvis such that they cause an obstruction during delivery. Women with pelvic tumors, they tend to to reduce the birth canal such that such that it leads to the same obstruction as they try to deliver the baby. So these pelvic tumors, they can be uterine fibroids, even any cervical or vaginal abnormalities. So these, they tend to reduce the birth canal. The normal birth canal is reduced. So now when it comes to the passenger, which is the fetus, so like post-date babies or large babies or big babies, they they present there's a disparity. In short, there's a disparity between the largest diameters of the fetus and the largest diameter of the pelvis. So there's a disparity which is going to cause CPD and causing an obstruction. Then we have got like abnormal presentations, or let me say malpresentations and malpositions. Malpositions like OPP, occipital posterior positions. These, they tend to cause an obstruction. Then malpresentations like in breech presentation, in brow presentation, shoulder presentation, even compound presentation. These, they tend to obstruct labor during the delivery. Then Also, these conditions of the fetus, like hydrocephalus, in short, the fetal anomalies, like hydrocephalus, these they present with large diameters. Their diameters, they are increased such that they cause a disparity as they try to negotiate the birth canal, or as they try to engage themselves in the inlet of the pelvis. You find that there is a disparity which is going to cause CPD. Then conditions which are common, like in multiple pregnancy, which are locked twins. Locked twins, they cause an obstruction. They cause an obstruction. So that picture shows a big baby, which it causes a disparity between the same diameters that is it is presenting with in the maternal pelvis. So a full bladder also acts as an obstruction. A transverse lie acts as an obstruction. These are conjoined or siamese twins. They act as an obstruction. So contracted pelvises, like the one here. How do you expect a woman to deliver normally without an obstruction if their pelvises, they're like this? Because the normal pelvis of the woman, we expect it to be gynecoid, and it should look like this. It should be like this. Then the woman is going to present with no obstruction during delivery. Then these are now locked twins. As the woman is trying to deliver during the same delivery time, you find that the first twin, the whole body of the first twin is born, but the head there is stuck, and the second twin, the fetal head is born. There is an obstruction. These twins, they are locked together, which is causing an obstruction, such that leading to obstructed labor. So these are women with big babies. They are at risk of having an obstructed labor. So now let's look at the clinical features now of um, obstructed labor. You find that these women, they have a prolonged labor, which is going to exceed 18 hours. So there's prolonged labor which is going to exceed 18 hours. There's also maternal distress. These women, they are distressed because of the same prolonged labor, and they are starved. They stay hungry for too long and dehydrated. You find that the same um, being starved for too long and being dehydrated, it's going to lead them to maternal distress. Find that their mouth becomes dry due to the same dehydration. Then, since these women, they are starved, they can be metabolic acidosis. There can be accumulation of lactic acid. Then there is increase also in pulse due to the same. It can be due to pain, because these women, they are in pain. They experience pain a lot. So the rise in pulse rate, it can be due to the same pain, even due to the same dehydration. They can be caput formation and excessive modding, because this woman, it they have an obstruction. Let's say this obstruction is just at the cervix, and the cervix is not even fully dilated. As the woman is trying to push, there can be that caput which can be forming. At times the cervix is fully dilated, but the birth canal is small. As the fetal head is trying to negotiate in the birth canal, there can be excessive modding because it is trying so that it negotiates the same birth canal, which is small. So now let's briefly look at on how uh, obstructed labor can be diagnosed. How can we diagnose obstructed labor? How can we diagnose obstructed labor? So you find that on the general examination, these women, they present with maternal distress signs, like they are anxious, they are restless, they can be sweating. They find that their pulse is raised and the temperature, they are always high. But when you look at their pathograph for such women with obstructed labor, you find that the cervical dilatation, the progression is slow. You find that the dilatation can be found on the action line. It can even cross the action line, like moving to the right side of the action line. Then the descent is always slow. So on abdominal examination and vaginal examination, on abdominal examination, on inspection, you find that the bandage ring is noted because there's an obstruction. So as so this is the example, a picture of the bandage ring. So the other picture on top, it shows the normal shape of the abdomen. So the other picture shows the bandage ring. We have seen the lower segment being distended, and there's a ridge in between the upper segment and the lower segment, which has formed a bandage ring. So this is noted on inspection. Then the other feature that can be noted on inspection is a full bladder. A full bladder can be noted on inspection. So when you go to your palpations now, the palpations, maybe this obstruction, it can be due to malpresentations. So there can be a malpresentation which can be noted, or which can be felt rather, if the obstruction is due to the cell malpresentations. So there can be also no advance of the presenting part. As you palpate, you find that the time when you had assessed this woman or examined this woman is the same. The fetal head is at the same level where you had first examined her. So there is no advance of the same presenting part. Then on auscultation, because of the same obstruction which has occurred, there is the fetus is deprived of the same oxygen, like in the gaseous oxygen there is impaired. So the fetus can present with the fetal heart can be bradycardic or tachycardic because of the same prolonged strong uterine contractions. Because this woman is having normal contractions and they are always strong. And because of the same strong uterine contraction, but with prolonged labor, the fetal heart can be tachycardic or bradycardic. Then on vaginal examination, you find that when you do your vaginal examination, the vagina is hot and dry because of the same obstruction which has occurred. Then at times there can be offensive odor or offensive discharge. Then there is the caput formation which is noted because of the mother is trying to force the fetus to pass through the same impassable birth canal. There is a caput which is forming. There is excessive molding which can be noted during our vaginal examination. Then the membranes are always absent because in obstructed labor you find that the membranes they rupture early. Now let's look at on the brief obstetric management when it comes to the delivery, or what is the management of these women with obstructed labor. So the standard mode of delivery for obstructed labor is cesarean section. The standard mode of delivery for obstructed labor or for women with obstructed labor is cesarean section. Because this the same obstructed labor, they find that the baby can be bradycardic, as we have said. The baby can be tachycardic. In short, they can be fetal distress. Then why wait for a baby who is distressed, or why should we force an obstruction where the baby has already presented with fetal distress? You prepare this woman for emergency CS or for emergency cesarean section. So you care this woman, you start now caring for this woman pre-operatively, but in an emergency manner. So what things should you do as you prepare this woman for an emergency? Yes. So remember, if this is diagnosed or is noted, make sure you call for help. You mobilize other medical aids so that you work and you work as a unit, you work as a whole, so that this woman can be prepared as soon as possible for cesarean section in order to prevent the same IUFD. Because as we are delaying preparing this woman for OT, then there is also high chances of losing the same fetus and putting also the mother at risk. So you call for help. You mobilize other health personnel so that you work as a unit. Then, since there is bradycardic and tachycardic, resuscitate this woman, put her on O2 so that it can the oxygenation, the tissue perfusion can be adequate. As you commence the woman on OT, you are also benefiting the the fetus inside there. Then make sure you commence some fluids like Ringer's lactate. Um, no, if you don't have Ringer's lactate, then you commence some normal saline. But before you rehydrate or resuscitate this woman, make sure these women they are cannulated and the blood samples they are collected for investigation, such as maybe for HP levels, for grouping and cross matching. So those blood samples that are supposed to be collected and sent to the their respective labs. Then as you remember, this process is done concurrently and it is done on a short period of time, or at a short period of time rather. Then after you are done resuscitating this woman, make sure you give her psychological care, because this woman doesn't know what really is happening to her. She has just seen a number of medical personnel attending to her. So make sure you explain what is happening to her, then what has been done and what is going to be done. So that you tell her about the fetal well-being, how is it, and the indications why she has been scheduled for an emergency. Yes. So all that the woman needs to understand. Tell her, explain to her the aspect, the importance of signing the same consent form. So if she understands everything, if you give her now the consent form, so that she signs the same consent form. Remember this, it acts as a legal document for any legal proceedings. If uh, any complications was to happen in the same uh, or during the same operation, so it guides you as a medical personnel. So prepare her now physically, catheterize this woman. So this woman should have an indwelling catheter. So these women they're supposed to be catheterized just to prevent the cross infection during the same operation. Then if these women have taken anything, make sure you aspirate. But if they haven't taken anything, well and good, put them on new oral. Um, Make sure you do some observations. Do some quick observations as others are preparing other things for for the same preparations. So do some quick observations so that you know how far you have gone and how far the well-being both to the maternal and the fetal well-being are. How are their conditions in general. Assess, do some observations. Then make sure before the woman goes to theater, you do you load her with antibiotics IV like ceftriaxone 1 gram. Give her before she goes to theater. You can also you must first label the patient, like on the label it should contain the name of the patient, the gravid, the parid, the diagnosis and the type of operation which she's going for. So also you can even gown this woman in a surgical gown. Remember, these women when they are going for an operation, they don't use their normal clothes. Make sure you give them the surgical gowns just to prevent cross infections as the woman is going to be operated on. Remove all cosmetics Make sure you remove all cosmetics that this woman can be having, like the earrings, the rings, the artificial teeth, uh, the nail polishes, the jewelries. Remove everything that is not part of the natural body. Remove everything. Then make sure that before you even take for theater, make sure that the theater staffs are informed about the case as you are continuing preparing this woman for the same surgery. Make sure that the theater staff, they are informed. Then before you take, do the latest observations and document on the patient's file. Then as you take this woman for theater, make sure you carry with you now the patient's file, the laboratory results, and everything related, any documentation related to the patient. Carry with you. Then as you go there, make sure you give handover to the theater nurse, mentioning whatever that you have done, like mentioning the latest vitals, mentioning the pre-medications which has been given, mentioning the name of the patient, the parity, mentioning the age of the patient, also the indication for the same type of surgery that she has been brought for. So that was a brief pre-op emergency, or emergency pre-op, or emergency pre-operative care that we give to women with obstructed labor after being diagnosed of it. So now let's talk about what are now some of the complications of obstructed labor. What are the complications of obstructed labor? So the complications of obstructed labor, one, we can say they can be uterine rupture because of the same continuous uterine contractions. Those strong uterine contractions, if they continue and there is an obstruction, then the uterus can rupture. They can be PPH because of the same uterine inertia, rather inertia. Because of the same uterine inertia, this woman is exhausted. So the same uterine inertia can cause postpartum hemorrhage. They can be VVF, they can be RVF, like vesicovaginal fistula, they can be rectovaginal fistula because of the same fetal head which has stayed for that position, and it has compressed the maternal tissue, which has caused ischemia, which has led to necrosis of the same. Then the end result will be VVF or rectovaginal fistula. Then there can be neonatal asphyxia, there can be cerebral damage, there can be fetal distress, there can be maternal distress, there can be infection because of the same membranes which tend to rupture early. So those were some of the complications of um, obstructed labor. So I know there are a lot of complications. Just feel free to add, being a discussion for the day. So in summary, we have said um, obstructed labor, it's a complications, or it's a complication of delivery. But being an obstetric emergency, there is a failure of the presenting part to descend in the birth canal, in spite of good uterine contractions. But the faults, they can be either due to the passage or passenger. So this obstruction, it can occur on the either on the inlet cavity or outlet. So that was our topic of discussion for today. Don't forget, we are on Thrive Academia Corner. Don't forget to subscribe as we keep you updated on the incoming uploads. Thank you.